There seems to be an innocuous background, but then this is what it is. You can't be in Sundarban and avoid tigers. Okay? So you are in skull base. Skull base is the territory of internal carotid, and we can't avoid internal carotid. So better is to be familiar with its anatomy and its presence. So there are multiple systems of classification of carotid. So most common system which has been used for years together is the Fisher system. There has been a Roton system, there is a Boot-Hiller system, and there is a last joint system. So most of them ask me a question on why the carotid does not fall in a straight line. It keeps turning and twisting and on the way to go to the brain. So it is actually a segmentation. These are the segmentations, these are the embryological segmentations, and this is how the dorsal aorta is. So that is why the carotid is having a tortuous course. So what are the landmarks for carotid? So if you see the lateral view of the carotid, you can see that there is a parapherral carotid, then you have vertical petrous, horizontal petrous, you have the lateral carotid, then you have the cavernous carotid, then you have the communicating segment and the clinoidal segment. So what are the landmarks? The most important landmark is for the C1 when you do endoscopically is the styloid apparatus. So you have to identify the styloid apparatus. How to do that, I will just take it on my presentation. The second important thing is to look at the landmarks on where the carotid turns. So the laceral carotid becomes a petrous carotid at the foramen lacerum. So we need to find out on where it is. The most important landmark is the median canal, which has been published all over. So I take 6 different landmarks to identify this key structure which forms the crux of skull base surgery. So this is the dissection video. So you can see that this is the pituitary, and I have done a medial cavernous dissection. I'll just paint and show on how I dissected carotid. See, this is the carotid on the other side, this is the carotid on this side, clinoidal, cavernous, clival, laceral, and the petrous carotid. So the whole of the carotid was here. This is the optic nerve, and this is the anticlinoid pneumatization. This will be the lateral opticocarotid recess, and this is the medial opticocarotid recess. So there is lots of interests on where the laceral carotid turns, and this is a schematic diagram of the foramen lacerum. The styloid diaphragm is the landmark for the parapharyngeal carotid. We will look at it that way. And the stylopharyngeus muscle. This muscle protects the carotid. So until unless you damage this muscle, your carotid is usually protected. The next landmark I look at is the occipital condyle and C1 condyle. So where they meet is just laterally you will have the carotid artery. You can see here. So this is where the occipital condyle and this is C1. So when you come from endoscopically, this is just laterally, it is there, and we usually don't encounter carotid there by dissecting too much. So how to do endoscopic approach safely? Do a transthyroid approach, take the C5-C6 junction, follow the roof of infratemporal fossa, take the foramen ovale, like get the spinosum, dissect the eustachian tube up to the bony eustachian tube. Carotid is always medial to the eustachian tube. So eustachian tube usually protects the carotid. And then you identify the styloid base and stylopharyngeus muscle, you will never miss the carotid. So this is the C5-C6 junction I was telling. These are the 6 landmarks I take. Median canal, pterygoid wedge, pterygospinodal suture, fossa prosonumella, you have the eustachian tube and the laceral cartilage. So this is a small video clipping. So you can see that I am punching out, this is the median canal, and I am expecting the carotid to come like this and travel laterally. So this is the median canal, okay? So this is the carotid. I am confirming the carotid now, I am using the drill. So you can use drill, debrider, you can punch, you can use blade until unless you are extremely confident on where your carotid is. So I am drilling the contralateral clival carotid, and this is the clivus which has the clival chordoma. I am resecting the base, and this turn is a good landmark for carotid and for the 6th nerve. So you can see this is the tumor. So all my skull is teamwork, and I have a set of neurosurgeons who help me do intradural work. The starting part of the drilling and the tumor dissection is done by me, followed by the intradural work by the neurosurgeons. So you can see this is the angled endoscopic view of the same tumor, and I am doing a infrapetrous approach to the petrous apex. So this is the posterior fossa dura. There is a small breach and the tumor has gone there. So this is the median canal, median nerve, and then once I am below the median nerve, I can be in the foramen lacetum and I can use debriders, I can use blade. You will never injure the carotid. See, I am using a tool cut and I am cutting it out. So then I have drilled the lower extent. So here we do something called as the translacetal approach, where I cut the laceral cartilage and then that opens up the petrous apex for us. This is the petrous apex, that is the posterior fossa dura. This is the angled view. You can see I am removing the tissue there, and then I have given a cut here with a 11 blade onto the cartilage which opens up the petrous apex. So then we do the intradural dissection. This is what the neurosurgeon does. And you can see the basilar artery. And we are removing the tumors from there. You can see the sixth nerve here on the other side, right side. That is the sixth nerve and the pons. We'll be looking at the sixth nerve on this side too. And then it is reconstructed. So then I wanted to show you the clinoidal carotid dissection. For clinoidal carotid dissection, the landmark is middle clinoid. So this is a tuberculum meningioma. So I am doing endoscopic exposure. You can see that the base of the tumor is removed. And then you can see that I am doing a skull-base craniotomy. Once the craniotomy is done, then you can see how close the carotid walks. This is the craniotomy. You can see the tumor is dissected and it is descending. You can see the subchiasmatic cistern. So the white structure you are seeing is the optic chiasm and the subchiasmatic plexus is seen. Once you remove the tumor, you will be seeing the clinoidal segment. The landmark for clinoidal segment is the middle clinoid, which you can see here. This always protects the carotid and the ophthalmic origin. You can see that is the carotid artery, and you can see the ophthalmic artery origin there. And then reconstruction is done. See, as long as the community segment is there, the BCOM is the real hero. So as you can't injure BCOM, you can injure the carotid and get away with it, but not with a BCOM injury. So this is the exposure, and after durotomy, you can see the tumor is internally debulked. I open the optic canal. Once we open the optic canal, it gives a very clear plane on the optic nerve, tumor and the carotid. So this is on the other side. So you can see that this is the tumor. The infralateral part of the tumor, you have the stalk. So I will show you the pituitary stalk. This is the optic canal which has been opened on the right side. So this tumor is being mobilized from all around. You can see that this is the stalk. So overzealous mobilization can land up into pituitary dysfunction. So the stalk is very clearly dissected, the tumor is bipolar and the stalk is saved. So once you stay the stalk, the tumor is rotated medially. All this rotation is possible only by doing a generous tumor decompression. You can see the BCOM here. This is the stalk.
So we'll move on to the second topic, planning surgical approaches in lateral skull-base pathologies by Dr. Ruhi Singh.
I thank the organizing committee for giving me this opportunity to speak upon Planning surgical approaches in lateral skull base pathologies. Lateral skull base consists of many units. These are bone units and soft tissue units. Bone units are mastoid, labyrinth, middle ear, cochlea, petrous apex and occipital bone. The soft tissue units are skin flap, sigmoid transverse sinus, dura, brain, the lower cranial nerves, internal carotid artery, jugular bulb, etc. Due to the presence of various contiguous critical structures, a very careful surgical planning is required for a perfect surgical outcome, and this can be achieved by targeting the lesion, choosing the entry door and linking the two of them so that the access is maximum, surgical effect is up to the mark and there is minimum collateral damage. This being a very vast entity, I would restrict myself to one pre-presentative case each of congenital, traumatic, inflammatory, neoplastic non-vascular and neoplastic vascular. Clinical findings, radiological images, available literature, personal experience and the teachings of our gurus and param gurus have paved the path for me. Cases were discussed in neuroradiologic conference at our institute and the consent for photography and videography has been taken. My sincere gratitude to my guru, Dr. Alok Thakkar, Brigadier S.K. Singh and my mentor, Dr. Shankar B. Madikari. Case 1 was a 4-year male child with bilateral congenital non-syndromic sensory neural hearing loss with inner ear malformation. The MRI brain and inner ears were studied and it showed a right labyrinthine aplasia and absent cochleovestibular nerve. On the left side, a hypoplastic cochlea was seen with a dysplastic vestibule and a common cochleovestibular nerve was also seen. HRCT temporal bone axial sections were studied at the level of posterior tympanotomy and we found that round window was absent. Distance to be drilled to reach the cochlear lumen was 3.4 millimeters approximately, but even a slightest change in angulation of drilling could have misled us to the internal carotid artery, which is marked in red. We further studied the axial section at level of processus cochleariformis and we found that stapes is malformed. There was a good promontory bulge, however. And drilling perpendicularly towards the hypoplastic cochlea, we could reach the cochlear lumen and the distance was very less, that is 1.8 millimeter. The axial section also showed a wide cochlear aperture and therefore we expected a CSF gusher. Also, the electrodes could have been misplaced into the internal acoustic meatus. So the issues were absent round window, but yes, we had a good promontory bulge. And so we planned to access the cochlea by drilling perpendicularly over the cochlea after identifying the oval window by an extended posterior tympanotomy approach. CSF gusher was anticipated and we were ready with head-up position or mannitol or hyperventilation. Hypoplastic cochlea and wide cochlear apertures were there and so we had test electrodes available with us and intraoperative imaging available with us. With guarded prognosis, the child was taken for cochlear implantation on the left side. Promontory was drilled perpendicularly. We reached the cochlear lumen and we encountered CSF gusher, which was very wisely dealt. Cochleostomy was widened. Test electrodes were inserted, followed by the insertion of actual electrodes. This was then followed by good sealing of the cochleostomy area with fascia, muscle and tissue, followed by fluoroscopic image which showed intracochlear electrodes. So in case 1, intraoperative findings of round window being not visible, promontory bulge present, stapes deformed and CSF gusher, incomplete electrode insertion. All these correlated well with our pre-operative radiological management. Case 2 was a 37-year male with right aortic capsule involving temporal bone fracture with CSF otorhinuria following road traffic accident. The patient had a right profound hearing loss and a B-type tympanogram. In the first